Good afternoon. There we go. Great. Welcome to the third Mondays in March. I'm Steve Campbell with Marketing and Communications. Dr. Callender decided to take a few days off, so I'm filling in for him today. But before we get started with Ms. Sadro and the Business and Finance update, I did want to do a recap of some of the highlights that Dr. Jacobs spoke about last week. There were many, so we're just going to highlight a few and give a couple of quick summaries. First of all, the UTMB's research continues to expand, and we've had impact truly across the globe. A couple of examples of how that's playing out is this year, the Seeley Institute for Vaccine Services was created based on the previous center's internationally known contributions to vaccine services and the Seeley and Smith Foundation's generosity to founding that institute. That institute is going to increase vaccine development and drug discovery. We've had some pretty remarkable breakthroughs related to Zika and Alzheimer's. The CDC awarded UTMB $10 million to establish the Western Gulf Center for Excellence for Vector-Borne Diseases. Yet again, is another great proof point of how we are internationally recognized for the contribution in that area. And UTMB also increased its research funding by more than 20% over the past 5 years. If you think about it, that's a pretty remarkable number when you look nationwide about the decrease in funding that's actually available and then the increased competition it takes to get that. So for an academic medical center to increase by 20% is actually really pretty amazing, so congratulations. A few plans for the future for research is we're going to selectively be expanding our informatics core. We're going to optimize and grow clinical research and the number of clinical trials that we're actually conducting here, all of which helps to get new treatments to the bedside even sooner. And with the opening of 17E, we'll be enhancing the research space that we have available. Our schools are continuing to do an excellent job of educating the health providers of the future. Across all of our schools, enrollment has increased 36% since 2009. We had the SAC survey this past February. We established doctorate degrees in clinical laboratory sciences and occupational therapy. The School of Health Professions is among the top 15 NIH funded nationally, which is quite an achievement. A few plans for the schools for this year. We're going to actually celebrate the 50th anniversary for the School of Health Professions this year. We're going to open the Health Education Center, which will really transform the way in which we do interdisciplinary training for the health providers of the future. And we're going to develop UTMB Education 2025, which is the educational strategic plan. I think Dr. Jacobs also reminded us of a very important phrase, which is no margin, no mission. And so we've had a lot of conversation about the environment that we're in, the market that we're in, and those financial challenges that is challenging us with. So the academic enterprise we'll be doing a few things to increase efficiencies and look at expenses, but we also need to continue to invest in really target areas. A couple of things that we're going to hopefully see is reduce outmigration of referrals. We're going to continue to improve access for our patients. We're going to ensure that our advanced practice providers are practicing at the top of their license. We're going to ensure we're market competitive for the war on talent and for people. We're going to challenge vacant positions. We're going to expand the scribe program. And we're going to review things like the device and the computer allocation and the way in which those things are done. Many other great highlights. If you weren't here last week, I'm not going to go through the whole presentation again, thank you. But please see it online, and you can hear many of the other plans as well. As a reminder, next Monday is the final Mondays in March. It will be a panel discussion with Dr. Callender and the 3 EVPs where they're going to be addressing and answering many of the questions that I know you all have. So with that, I'd like to introduce Ms. Cheryl Sadro, our Executive Vice President and Chief Finance and Business Officer. Take it away.
Thank you. Good afternoon. How's everybody doing? You survived spring break on the seawall, right? I actually drove in this morning and it took me about half the time that it did last week, so that was nice. So today, I want to say thank you for those of you that are here. Thanks for folks that are coming in remotely. We really appreciate you taking your time to be here. What I want to talk about today, there's 3 topics here. They're very similar to the topics that we talked about last year, but I want to make sure that we cover them. As I thought about this, I assume many of you probably have a lot of questions about the financial position that we're in at this point in time. So we'll take a good bit of time and we'll go through that. And I hope after we do that, you'll have a much better understanding. If you don't, raise your hand, ask questions, not a problem at all. There's also a lot of information out there in the media about academic medical centers and how academic medical centers, frankly, some of them are struggling these days. So I want to talk a little bit about why that is, what's going on, and what we think we can do to help ourselves out and hopefully learn from others as well. And then we'll take a look at what BNF has done, Business and Finance has done this year so far. And then we're going to have a little surprise, and we'll talk about what the rest of the year might look like and what we might see in fiscal year 19 as well. So if we didn't cover everything you came here to hear, just let me know, and we'll be sure to do that. So let's talk about the budget process. So everybody knows that we're off target a good bit so far this year. Does anybody not know that? Now you do, I guess. So I want to talk about where we begin. If you talk about how we develop our budget, that's the first place that we begin to say, okay, we're off target right now. We had a budget. What's the deal with the budget? And I thought it would be very important. Normally, I wouldn't put you through this exercise, but I thought it would be really important to hit the high points of how a budget's developed and how we develop our budget. So let's start from the beginning. First of all, the EVPs get together, and I can't stress enough how much of a team effort this is. We get together with Dr. Callender, and we talk about first, overall, what that adjusted margin target should be. So it's a combination of what we've done in the prior years. It's a combination of what we think the regents will want to see from us, and it's a combination of what we think we should achieve as an organization. So once that is done and it's agreed upon by the four of us, we move on to what is number 2 here, the target allocation. So somebody has to take a piece of that margin, right? And for years, we've allocated that margin based on a particular mission's expense percentage to total expenses. So if, for fun, we had $300 worth of expenses in our organization, and the health system had traditionally represented 50% of all expenses, they would get $150 of that $300 target. Does that make sense? Okay. The next thing we do up here is called global assumptions. That doesn't mean global like in the world. That means global as in what would be the assumptions that apply to everybody, okay? So let's talk about what those are. They are things like supply expense, merit increases, and payer reimbursement rates. So when we talk about supply expense, we know that in the marketplace, we have some data that tells us that supply expense may have an inflationary increase, although inflation's fairly low these days, but supply expense may have an inflationary increase of 2 to 5%, okay? That's a global assumption that we apply across all of our supply expense. And that percentage is an increase over the prior year, okay? In terms of the payer rates, the payer reimbursement rates, we know as we contract with the payers, and when I say that, I mean the Blue Crosses, the Uniteds, the Aetnas, we understand usually those contracts are done for a 2 or 3, 4 or 5 year period. We understand what we will be paid for under those contracts. So we understand globally, again, what we will be reimbursed. There are factors in there. There's some factors that have to do with volume and acuity and all of those things, but for the most part, we understand what will be reimbursed. And then merit increases. Now, nobody throw anything at me because I know we have postponed merit increases for this moment, but the merit increases are at a basic percentage, a global percentage, that we apply across the system, with the exception of the faculty compensation plan, which is separate from that. Okay, does that make sense? So let's talk about volume targets. I'm sorry, health system assumptions. I was coming way down here. There are certain things that are informed by the health system. There are certain things that are informed by the academic enterprise. There are certain things that are informed by business and finance. When I talk about health system assumptions, I'm talking about things like targeted case mix index, and I'll talk about that in a second, length of stay, and other items that would be specific to the health system. Those are largely based on trends and assumptions that we make at the time of the budget. So let's talk a little bit about what that means in terms of case mix index. Does anybody here know what case mix index means? Gulshan, raise your hand. If you don't know what case mix index is, that's okay. It's a measure of acuity, basically. So if you start with a 1, and that's a person who's in our hospital, we understand all their conditions and so forth, and then you build on that for somebody that comes into the hospital that might have more than one condition, they might be sicker than diabetes and so forth, then we get paid a little bit more. We may get a 1.1, a 1.2, a 1.3, and that's applied to a rate. So we may get paid a little bit more for every acuity or comorbidity that the patient has, okay? So when we look at case mix index, that's extremely important when we talk about how we're going to get paid, revenue, all right? Last year, we were on a bit of a trajectory that our case mix was increasing, and we assumed that trajectory would continue, and that trajectory's kind of flattened. And I'll talk a little bit about why that's happened in a few minutes, but those dollars, as odd as it seems, those dollars are pretty big. So when I said a 1, and then you go to a 1.1, every 0.1 is worth $15 million to our organization. So you can see real quickly how if we don't experience the same acuity that we might have in the past, we'll talk a lot about that, how that can really impact your bottom line. Let's talk about academic enterprise assumptions. Where's Lauren? If I get this wrong, where's Lauren? There's Lauren. Will you tell me if I get this wrong? All right, or Dr. McCollum. Academic assumptions are things like new faculty hires and new and existing faculty activity that maybe are determined by the academic enterprise. They're discussed amongst all 3 of the EVPs. We talk about them. They may be hires for specific specialties that we know we'll need. They may be family practice physicians, just depends on what the need is for that year. They may be research faculty as well. So those folks that process rather, is something that the academic enterprise goes through each year, and we all sit down and talk about it, we all agree on it, and then those assumptions are put into the budget. All right, I think I can get this now. So volume targets, here I'm talking about discharges and outpatient visits. Those are largely informed from the health system in terms of what they think they can do in growth from a discharge perspective. So how many patients are going to be coming into Jenny, League City, Angleton, so forth, okay, and what we think that we'll be able to grow, as well as outpatient visits, what's going to happen in the clinic process. When we talk about volume, and we talk about new hires, and we talk about those types of things, those are determined a couple of different ways. If we're opening League City Hospital, and we are open now, but when we expand League City Hospital, we're going to have to talk about how much volume in terms of discharges we think we will increase versus where we were before we opened the new beds, okay? So there are differing times when new things come on. If we don't have new things, those volumes are often looked at as what happened in the last year, and were there any significant non-growth events that we think might happen. So we look at a 12-month trend, and we say, okay, we think that we did 2,000 discharges last year. We may increase 1%, and that's the layer that we'll put on the discharges for the next fiscal year. Have I confused everybody really bad? Got it? Okay. All right. So then let's go back and talk now about other assumptions. So we've talked about revenue. We've talked about discharges and outpatient visits, and we've talked about faculty hires. faculty hires. Now let's talk about the other things that are down below all that. There are things that come from UT system in terms of estimates. So as many of you may or you may not know, all of the investments for UT system are held at a central department within UT. So they've hired professionals that know about investing, probably much more than most of the campuses do. So they target what investment income will be and then what other non-operating expenses might be. Some of those are targeted by them. They look also at circumstances and what they think past performance will be, but they give us those projections. So you take all of that, you put it in a big soup pot, you turn it around, stir it, and then you come out with a budget that you submit to UT system. So my point here today is that there's a lot of confusion, I think, about what happens in that budget process. There's a lot of folks working on it. It's a big team effort, and there's a lot of components. I want to talk now, I want to move into a little bit about, okay, the budget was prepared. It wasn't drastically different than our prior year budget in terms of the total bottom line. So why do we see ourselves off budget so much this year? This is where we're at today. So in terms of our fiscal year 2017, February year to date, so for the first 6 months of fiscal year 17, we had an adjusted margin loss of $9 million. Through that same period of time in fiscal year 18, we have an adjusted margin loss of $15.1 million. It's a $6 million variance, and we had budgeted to be a positive 10.9. So overall, we're off budget by $26 million year to date, okay? Why are we struggling? So this is a pretty simplistic view of this, but these are the major buckets. This is where we see ourselves having issues right now. Let me talk about, I'll just start from the top and we'll work ourselves down. So the first one is a significant business interruption from Harvey. So while Harvey happened in August, we felt the impact of it. We still are feeling some of the impact of it, but we felt the impact of it in September, in October, and November. We've estimated that impact, and this includes the clinics as well, and physician volume, we've estimated that impact to be about $9 million. You have seen this slide. Let me stop and back up a little for a second. You've seen this slide. Donna, I think, had it in her Mondays in March, and Dr. Callender talked about it at Town Hall. When Dr. Callender presented this, it was as of December, so this is now as of February. So these numbers have grown some, as you would expect, and they'll be a little bit different than what you saw in Donna's presentation as well. So let's talk about that next line that says, cases are not as acute as in fiscal year 17. What's that mean? So there's folks out there, and you probably say, hang on a second. I'm taking care of really sick patients. What do you mean they're not as acute? And you know what? We are. We're taking care of really sick patients. When I say this, I say that when we build the budget, remember I talked about looking at discharges and outpatient visits. When we build a budget, we build it on history, because we don't know what the future holds at that moment. We can kind of guess, but we don't know. So we build it on history. So when we look at what we thought we would have in discharges, we also had to look at what the acuity of those discharges, how sick they would be, that case mix index, the 1.0 plus 0.1 plus 0.1, so forth. So cases not being as acute as they were in fiscal year 17 means just that. Let me give you an example. I'll give you 2 or 3 examples. This time last year, in fiscal year 17, we had done 2 heart transplants. And you say, okay, well, great, Cheryl, you did 2 cases. There's only 2 cases, but they were worth $1 million to our bottom line. Will we see heart transplants this year? Maybe, maybe not. But we based it on the history that we saw last year. In the same respect, we have seen about 27 less orthopedic-type cases. Whoops, there's a hole in the floor. You can laugh, it's okay. So I didn't fall. We've seen 27 less orthopedic cases than we saw last year as well. That's about another 800,000. There are a series of other cardiac type cases that we haven't seen this year that we saw last year, and that's about $2.3 million. We can actually look at the data that we have and make up the rest of that $13 million as well. So we're just not seeing the volume of the acute cases that we saw last year. Why is that? We think a lot of that probably has to do with Harvey. There's some studies out that talk about what healthcare revenue has done since the hurricane in Florida as well as the hurricane here. And in the beginning, in the first couple of months, we know that the revenue had dropped about 65% for hospitals in those hurricane-battered areas, if you will, and that it's actually not fully come back yet. They're still at about 5 to 10% down in revenue. What we think is causing that is people are rebuilding their homes and they're really trying to take care of their families. So they're putting off those things that probably that they can. They just don't want to incur the expense, or they don't want to incur the time away from their job and so forth. All right, now stick with me here, because now I'm going to talk about case mix index documentation. That's the $14 million. If we have an individual that is ill and they come in and the physician documents in the chart, okay, this person has had a heart attack. Don't look at me and laugh, Dr. Jacobs, because I'll probably mess this up really good. So if a patient had a heart attack, and then we figured out that they had diabetes, and then they had hypertension, the more we document about those comorbidities, the better we get paid. Now, that's a crass thing to say, I know, forgive me, I'm a finance person, but that's how that works. When you see a case mix index documentation variance, we're saying that while we might be seeing those same types of, or that same volume of activity, we're not seeing it documented in the manner we thought it would be. Now, that's not a physician thing. We simply thought that case mix index would continue to trend up, and it's not. So there's a volume piece. We're not seeing as many. And then we're saying also there's a piece that says, for what we're seeing, they don't appear to be as acute, or the documentation doesn't indicate that they are as acute as they would have been last year. And you can see that both of those together are about $27 million. Does that make sense? The doctors are going like this. Everybody else is going, The other items here, they're smaller, and I don't mean to make light of them being smaller, but the faculty group practice, FGP, some of the decline in revenue I already mentioned is up in the Harvey line, that $9 million. This is just other revenue that might be, maybe we plan to hire physicians and we haven't been able to bring them on board. Maybe some of our younger new physicians aren't ramping up their volumes as quickly as we thought, those types of things. Reimbursement rate, so another $3 million. This was a lovely gift. The state legislature, after we finished our budget, actually came back on certain contracts and reduced our reimbursement by what is now about $3 million. In December, that was about $2 million, so we will continue to feel the impact of that as we move forward in the fiscal year. Outpatient at 7, that's primarily a decrease in outpatient volume in addition to what we saw for Harvey. And grants and other revenues, grants are a little tricky because you don't exactly know when you're going to get the actual revenue that comes in the door. So this is probably more timing than anything else. So there's good news. There's some black numbers down there that total to $24 million. They deal with salaries, wages, and benefits, supplies, services, and others, and depreciation. So I'll say right now that the health system has done a fabulous job over the last 3 or 4 months working on overtime and contract labor. They were running at some pretty high percentages, and when I say high, I mean compared to their peers, and now they've brought those back down a good bit, and that's where we're seeing a fairly good piece of this favorable variance in salaries, wages, and benefits. So, what's all that mean? There's a hidden kind of message in here that I really would like everybody to understand. This is happening across all health institutions in the nation. You'll see that we're off about $56 million in revenue, and we're better than budget about $26 million or $24 million in expenses. So our revenue is not keeping pace with a normal increase in expenses. Does that make sense to everybody? And that's happening everywhere. While we are continuing to receive reductions from Medicare, Medicaid, payers, you name it, we're still having to increase our expense structure. This is going on, like I said, across the country. All right, one more slide. So what does the rest of fiscal year 18 look like? Well, not one more slide, several more slides, but this is the rest of fiscal year 18. This projection says that at the end of the year, we anticipate being off budget by about $45 million. That's nothing more than where we are today and straight lining it for the rest of the year. We're not seeing that pickup in revenue that we would hope to see from the factors that we just talked about. All right, so then you're like, well, okay, so what's everybody going to do about this? So there's a lot going on. Some of you probably have been part of it, some maybe not part of it, but what's going on are the EVPs have a pretty robust set of plans that we're looking at. We're looking at revenue generating opportunities, and we're looking at options to reduce cost. Donna said this in her Mondays in March, we're going to need to grow and cut costs at the same time. That's the reality for most healthcare organizations today. We're going to need to continue to grow. We're going to have to find ways to increase the top line, i.e. revenue, and manage and be more efficient. So let me tell you some things that we're looking at. We're looking at pursuit, that sounds like a comic book, pursuit of high acuity cases so that in some ways maybe we can return to fiscal year 17 levels. I talked a little bit about what we read nationally in terms of a decline in revenue for healthcare organizations that were in those hurricane-stricken parts of the country. That may have had something to do with what we're experiencing, and we may see some of that come back. A large opportunity rests in our clinics in terms of receiving referrals from our primary care physicians to our specialists. It comes from outside referrals from physicians and how we develop those relationships. Donna talked about, in her Mondays in March presentation, looking at access and scheduling. If you remember, she talked about dynamic scheduling, which is a concept that says if we have 10 patients coming in the clinic for the day and 2 of them call in and they can't make it, what's the process that we quickly call patients that may be on a wait list and get them in? So being dynamic about our scheduling. Haven't always been really great about that, but we're doing a much better job these days, so that's a very important aspect. How do you overbook? So, you know, the airlines today, if you've flown recently, they'll overbook flights like crazy. They don't pay you enough to not accept your flight and go to another one. But we know, we have data that says Dr. X may have a no-show rate of 2%. So why wouldn't we take the data that we have, forgive me for this, guys, and overbook 2% if we know that 2% aren't going to come in? So overbooking is one of the concepts that Donna talked about. We also want to look at a reduction in expenses. So Danny said, straight no chaser, I think, when he introduced, who was the musician? Thank you. So let me just talk about this real quick, because I talked to Dr. Callender about this over the weekend. Here's the message. There is no plans here to have a reduction in force, because people hear reduction of expenses, and that's where they go immediately. We need everybody to help us with effectiveness and efficiency. We have a lot of things that we can do here, And we're going to talk a little bit about those. We have, and we've provided to our partners, we have a tremendous amount of data that talks about things like cost within procedures. So we might say that within a particular service line, we know that we spend X dollars on supplies, X dollars on lab, X dollars on radiology. And we can drill that down to the individual physicians. We can look at comparisons. Now, we're not clinicians, so we're providing data. But we can look at comparisons and we can say, operations, maybe if you take this to the physicians, maybe you can talk to them and understand where there might be a way to get some savings on a particular procedure. That's huge. It's hard work and it's really detailed, but it's a huge way to get a reduction in costs. And then we can also do what the health system's done. In terms of overtime and agency, if everybody that has a say over supply or salary expense, if you can look at how much you pay out in overtime and agency and figure out ways to not pay that, be more efficient, that's a huge win for the organization. It's very expensive, time and a half, sometimes double time. And the other thing that might be a little more obtuse for some folks is, how do you look at your contracts within your specific departments? So if you're running a department, do you understand all of the major contracts that you have, what you're paying for? It's very easy for us sometimes just to say, oh, let's renew that contract, let's renew that contract, let's renew that contract, without really saying, do I need it anymore? Or can I go back to the vendor and can I say, hey, vendor, I can't pay you that amount of money now. Can we reduce that? You'll be surprised. You got to work with supply chain to do that, but you'll be surprised where you might be able to have some wins. Next on there is a review of clinical documentation and coding process. This is something we should do, in my opinion, probably on a quarterly basis. When I say review clinical documentation and coding, there are people out there, and it can be a little bit annoying, I know, but there are people out there that are experts in what clinical documentation should be and how to optimize clinical documentation, so we're paid what we are owed. What happens when a physician documents in a record is that a clinical documentation specialist comes back and they may say, physician, we might get a little bit higher payment, we might increase our case mix index if we documented this. If that's agreed to by the physician, that goes over to coding, and coding says, okay, I see what's been documented. My coding guidelines say I can assign this code to it. If they hadn't put this other thing in it, I would have only been able to assign this code to it. So we need to do more regular reviews of our clinical documentation and coding. We have that process underway, and we'll get that report within probably a week. So we'll be able to see where we need to have some improvement. The other things are things I think I've already touched on, so review physician and clinic volumes. Ann's working very hard on that. Review low and negative adjusted margin inpatient cases. I touched on that when I talked about the cost per case. And review of managed care contracts. There's a way that we can have folks come in and take a look at our managed care contracts, so our contract with Blue Cross, with United, with Aetna, whatever that contract may be, and they can tell us, well, maybe you need to ask for some increased reimbursement here, or maybe you need to look at this differently. So we're having a pretty detailed review of all of those contracts. We're kind of pulling back all the covers and making sure that we're getting as much as we can for what we're doing. So how does this impact you? We say this over and over and over again, but we need your help, all right? We need you to look at your areas. We need to look at how you consume resources, and we need you to help us think about how to do that better. So that means, and I'll say this again probably, and I'm guilty as everybody else in this room, do you turn out the lights when you leave at night? Is there somebody who's the last person out that turns out the lights? How many times did your mom and dad tell you, if you'd like to pay the electric bill, you can go get a job? So mine did, so it was bad. So turn out the lights. It's simple, but we're a big place. We use a lot of electricity. When you copy things, you can cut your copy paper cost in half simply by printing on both sides. Print on both sides. Do enforce in meetings looking at things electronically and not making copies for everybody in the room. It just isn't necessary. Because when you walk out of the room, they're all left on the middle of the table and nobody takes them with them. Think about those little things. It's also pretty good. I'm not an environmentalist, but it's pretty good for your environment too. We'll cut down a lot less trees. Thank you. Get the pitch for, yeah, okay. All right. Who in this room has heard, if you don't use it, you're going to lose it? If you don't raise your hand, you're not telling the truth. Okay? Let me ask you this question. What happens if you have excess right now, today? You just saw where we're going to be off target, what we think we're going to be off target for the year. If you have excess money in your budget and you go through this philosophy, if you don't use it, you're going to lose it, what's that do for the organization? Makes it worse. Makes it a lot worse. So while I get it, I understand, but if you don't have to use it, don't. It hurts the organization when you do that. It doesn't help the organization. And the last bullet point there is, God forbid, everybody has to learn more about your department finances, right? Pull back the covers a little bit. Look at what your finances say. We are more than happy to help. We've got some pretty bright minds down there in decision support and in each one of the areas. And they can come in and talk to you about what's going on in your department and your expenses, and we can help. They've been there and they've done that. So just knock on the door. What's going on externally? You've heard some of this from Dr. Callender. You've heard some of this from Donna a little bit as well, Dr. Jacobs. I bring this to you because we need to understand we're not alone here. There are some very big organizations, academic medical centers, that are suffering through the same things that we are. Brigham and Women's, this is a quote out of Stat Publications, where the person in my position said, we're not going to make 2017's margin, and the way we're going, it doesn't look like we're going to make 2018's margin either. Banner and UAHN merged together because Banner knew how to run health systems, and they wanted to help the University of Arizona. This Ascension piece came out literally 2 days ago. They have a huge presence in Michigan, and they are off target. The Michigan system is off target by 78% for the first several months of the fiscal year. So we're not alone, okay? Why are some academic medical centers and specifically struggling? We have a different mission than that for-profit world and that not-for-profit world. We're here to educate people. We're here to educate people that will take care of us and our parents, and our kids, rather. We have highly complex, specialized care. Not all of those folks out there, not all those community hospitals can do what we can do. In fact, very few of them can do what we can do. And we like to think we do some pretty good research, too. But all of that's expensive. What's happening in the payer market is that the payers are simply saying, you know what, guys, we're tight, too. Don't believe that. But we're tight, too, and we just can't simply continue to afford to pay those kind of rates because you're an academic medical center. You've all heard about the GDP and the fact that healthcare is now taking about 17% of the nation's GDP. That's a lot. And that's a well-known fact to all of our government agencies, to the communities that we live in, to the voters, and they don't like that. So we've got to figure out a way to provide excellent care that we provide and do it in a cost-effective manner. Consumerism, I love to say this, and I'm sorry if it makes people, they get bored with it, but my nephews, and now my daughter, I'll tell my daughter because she's a millennial, my daughter doesn't want to go to the doctor's office. My daughter wants to pick up her phone and have some app that she can put her thumbprint on and say, Here's my temperature. Oh, and by the way, could you look down my throat? Because I think I have strep. And please do that with my phone. Oh, and oh yeah, I bought one of those swab packets. I'll swab my throat myself. And this little app I have on my phone, I'll put it on there and you can see if I have strep throat or not. And when you call that prescription into the pharmacy, don't want to get in my car and drive. I have an app, just like I can have food delivered to my house now. I can have my script delivered, and I don't ever have to get out of my PJs. So we've got to think like that generation coming up is thinking as well. We've got to think about how to adapt to that. So how do we do that? There's new payment strategies. I've talked about this a little bit. I won't continue to bore you a great deal with that, but there are things out there that are risk-based contracts. There are accountable care organizations. We've all been talking about them for 10 or 15 years now, and they're here. Most of the payers today are not going to pay us on a per click or every time you go to the physician's not going to get paid. They're going to begin to ask us to take more risk. They have great data that tells us how well we take care of a patient, how much it costs to take care of a patient, and if we don't do it within their guidelines, they're going to come start taking money back because they know how much it should cost, at least they think they know, all right? We do have to expand. We've got to look at partnership opportunities. I can't think of a better one to use as an example as MD Anderson, a sister institution that we're going to do work with on our own campus in League City. That's a fabulous partnership opportunity. It benefits this, I'm not a physician, so I'm just saying this from my perspective, but it benefits the patients of League City, and it also allows services to be provided in a convenient place. People don't have to go to a lot of different places. I already talked about some delivery methodologies, so I do think telemedicine, some sort of how we do this on our phone is going to be big in the future. We have already, we've talked about this, Donna's talked about it in a lot of different venues. We have an excellent quality reputation right now. We always have. We need to build on that because that's going to be a huge piece of how we are paid in the future. How much quality do we deliver? All right, I'm going to switch gears really big now because I have to keep moving on. How am I doing on time? I'm not doing good. All right. Let me give you the skinny here, and if you want a copy of this slide, I'll give it to you, but I'll go kind of quick through this. We're going to spend about $419 million in fiscal year 18 on capital. You can see 201 of that's going to be clinical. Another $59 million will be IKE recovery. We still are doing IKE recovery projects. We think we have about another $40 million next year, and then we should be getting that wrapped up. Research and education has about $68 million. A very large portion of that's going to be the Health Education Center. And then from an institutional perspective, there's a lot of maintenance that has to go on around here, so there's about $8 million there. We have to account for all of our IT infrastructure. Todd spends money like crazy. Just kidding. He really does. I'm just kidding. And then League City, obviously that's going to be a big element of our capital. So again, if you want that, I will definitely let you get a copy of it. All right, a few business and finance highlights, and then we need to move forward with this. I put this up here just because I want everybody to understand. It's real easy. I'm going to stand on my podium here a little bit. It's real easy to say business and finance is too expensive, and business and finance can be expensive. But what this chart says is that as a percentage of total operating expenses, we've gone from 15.9 to 14.2 in a time of escalating operating expenses. So that 15.9 was before Jenny was open. You add Jenny on that, there's a whole lot of operating expenses. It's before we really had a bigger presence in League City. You add League City on, there's a whole lot more operating expenses. We've been really diligent about making sure that we keep our costs low. If you look at the delta between 15.9 and 14.2, that's about $36 million. So we haven't cut $36 million, but if we had kept pace at the operating expense level, if we had stayed at that 15.9, it would have been another $36 million to the organization. we have a little video for you. We couldn't get by without doing a video. So we have a little video for you where we went and asked our business and finance folks what they thought about certain things. If you'll watch this, then we'll move on to the next part.
All right, so when you look at your accomplishments and your contributions to UTMB, what are you most proud of?
Well, I think I'm mostly proud of being part of a team that's managing the John Seeley Hospital renovation project behind me here.
Nothing I do is by myself, so I'm proud to be part of world-renowned, known biosafety expertise, biocontainment expertise, as well as the research enterprise here at UTMB.
And we source over 200,000 applications a year, and we've been able to decrease our RN turnover rate by 3%. And so that means we're getting better quality candidates, and the hiring managers are able to keep those candidates as well. So that translates into saving dollars for the institution.
Okay. In your department, what are you most proud of that y'all contribute to UTMB over the past year?
Over the past year, we have been able to put together 3 key information technology infrastructure projects that will allow us to improve communications, both verbal and electronic, across the entire university and its remote sites.
The thing I'm most proud of is the PeopleSoft upgrades. We upgraded PeopleSoft Financials and HCM this year. We did that in a year.
What I'm most proud of with payroll services is the team spirit that we have, the day-to-day accomplishments, and the extraordinary accomplishments that were achieved during the PeopleSoft 9.2 upgrade, as well as Hurricane Harvey.
I'm most proud of being part of a team that is foundational to UTMB Discover, put meaningful and actionable data into the hands of that doctor or that nurse that's trying to reduce length of stay or prevent a readmission. Or another example is it allows a researcher to quickly query the UTMB patient population to determine whether a research clinical trial is feasible.
I take a lot of pride in the dedication that I give to my department staff, that they call me and that they know that they can depend on me to address their problem and it'll be taken care of.
Have somebody come on in.
Hey.
Okay, since you were photobombing us, do you know this lady right here?
This is Teresa. We rely on her a lot in this area. She is always available to do anything we ask her to do. When the magnet program came through last year, we had made this tree. All the units made these trees, and ours was so big that she helped us hang this thing. But yeah, I mean, she impacts, you know, the magnet certification that we received by helping us do this. So
UTMB Health, working together to work wonders.
So thank you for allowing us to take a look at what BNF has done this year. Boy, now I feel like I know how entertainers feel like when they stand on stage and the light's really bright. 4 people up here, you probably know them well. To my right, my far right, is Dustin Thomas. He's the Vice President of Decision Support and Budgeting. To my immediate right is Mike Schreiner, and Mike is the Vice President over Business Operations and Facilities. Newest member of the team is to my left, Vivian Cardo. She's the Vice President over Human Resources, and everybody knows Todd the Spender, Todd Leach. What we thought we would do real quick is just have a couple minutes for each person to talk a little bit about what they've done in fiscal year 18 and what they see for fiscal year 18 and then what's going to happen possibly for fiscal year 19. So I've asked Dustin to talk about UTMB Discover. We think that's a great addition to UTMB over the last year and a half, and we want him to talk about what some of the capabilities are. So Dustin?
Yep. So I have the pleasure of helping to oversee the UTMB Discover project, and that is not a project that lives just in the finance department or just in IT. We have experts all over the system in the research areas, in the ambulatory operations areas, within the academic enterprise, who are learning how to organize and put data together in a way that's meaningful to different constituencies across campus. So the rest of fiscal year 18 is actually very exciting for us. The thing I take away from what Cheryl talked about today is that the future of healthcare, and I am very jealous of my colleagues who keep retiring around me. I am not as close to that as I would like to be, but the trajectory for the remainder of my career and for the rest of us in this room is that it's not enough anymore if we're going to work in healthcare to just know finance. or to just do bedside care, or to just be a surgeon in the OR, all of us are going to have to know how to put the pieces together in a way that makes everything work well. And at the end of the day, that works better for the patient. They get a better experience. We get better clinical outcomes when we do that, and the financials fall in line when that comes in order. So most exciting to me is an opportunity to work with all of you on what data do you need to see at what point in time during your day in order to make the right decision and do the right thing. And I would challenge you that as you're sitting in meetings with your teams on a regular basis, if you don't have people in the room who can get you the data or work with you on what you might need, ask the question, how do we get them there? We will get them there because not getting them there costs us too much money and has a bad outcome for our patients. So in the clinical world, there's plenty of opportunity. UTMB Discover is not a tool just for our clinical world. UTMB Discover is a tool for education. We're starting to have exciting discussions with Dr. Sutherland and Dr. Mouton about how we use that as part of our interprofessional education, or how we educate our nurses and our residents and our health professionals about data as they're going out into this world of healthcare, because it's only going to get more complex as it goes forward. And inside of the research realm, we're doing a lot of work with the CTSA team to look at how do we build up our clinical repository so that we can quickly see how many patients do we have that might be able to participate with the study. Or if we're going to exchange or partner with another institution like MD Anderson or Duke, how do we get our data out there to help them? So at the end of the day, there's a lot going on with UTMB Discover, and I am very much looking forward to the rest of this year and next because I think the opportunities are huge.
Thank you. Appreciate that. Todd, in like a minute.
A minute?
A minute. Can you talk about what's going on in IT?
I sure can. First of all, you guys all look great. Actually, I can't see a thing, so sorry, just kidding. But yeah, with regard to IT, certainly one of the big things we're focusing on is really trying to make information systems more efficient for you to use. We could spend more, but as you probably figured out, they don't want us to spend more. So what we want to do is actually make those usable and actually make sure that if we really have a future that expects more efficiency out of healthcare, then obviously the information systems have to support that. And I wish I could say there was a day, there will be a day when information systems truly do adapt to you instead of you having to do as much adaptation to them as you do today. But I think that's one of the things we're really trying to focus on next year. If you look back 5 or 6 years and you look at all the new things we've put into place, lab systems and revenue cycle systems and upgraded existing systems, the truth is every information system implementation is a compromise. You're sort of working what functions can you put in place against what time. And so we really need the next few years to be about how do we make these systems we have be more efficient for you, and how do we upgrade and apply. That way we have the bandwidth to sort of apply the new technologies as they come out so that we can apply them to the work you're actually doing. So that's really what I see us looking at, kind of stay away from the new shiny object and really focus on how do we get the most return from the things we've already invested in. So that's what I see for the next couple of years.
Thank you. Mike, you want to talk about BOF a little bit?
I can. We cover a lot of territory, but I'm really proud in 18, as we've got through this first 6 months or so of the year, our environmental health and safety team, along with our property services team, was instrumental in working with the CDC. We received our recertification for our Select Agent program, which is really the underlying certification for the Galveston National Lab. So it's a very important thing for that triannual inspection and certification, and very proud of that work. We also, on the utilities front, are just wrapping up the construction of the West Utility Plant here in the Galveston campus. Combination of that plant with our East Plant and about 10 other emergency generators that we have recently purchased and elevated around campus gives us enough emergency power on our Galveston campus that we can run all of our critical systems off the grid if we need to. The good news about that is, since we're generating some of our own power, we actually have worked out the relationship to sell electricity back to the grid. And the combination of that has allowed us to reduce our utility budget, both this year and in the years going forward. So we're happy to have that in place. And then The other piece that's so important right now and so visible is just the growth that's occurring on the mainland, the League City campus, and many of our clinics from Angleton to Beaumont, and getting those resources in place for our strategic growth plan. As you look at next year, really a lot of emphasis on expense reduction. Our supply chain team has done a great job over the last 3 years. They've actually reduced our supply expense by about $25 million in the last 3 years. Now that's low-hanging fruit, so every day it gets a little more difficult to produce an equal amount of savings, but we know we need to do that, and so as we go for the balance of this year and into FY19, the whole idea of focusing on our existing contracts, existing vendor relationships is going to be key for us reducing those expenses. I think finally the issue of growth on the mainland, and particularly our League City campus, puts us in a position that we're not really used to. We've been somewhat spoiled in Galveston. We have a good infrastructure. We have solid infrastructure on our utilities, power, water, etc. And our providers in the Galveston area know who we are, take very good care of us. We've not found that in League City. We have a lot of work to do in League City to bring the infrastructure that's coming to our campus from the municipalities, and this is somewhat true in Angleton as well, up to the standard that we think is important for UTMB to maintain the services that we provide. So we've got some work to do there, and that's certainly on the horizon.
Okay, Vivian, I don't mean to cut into your time, but we need to leave a couple minutes for general questions. I know.
I can't say my name in 2 minutes.
I know, right? So
I want to talk about a few things that we're working on. HR is working with various groups across the campus very collaboratively to help improve some of our processes. And I heard on day one that our e-performance system and our tool is one of those that gives us a little bit of heartache, I've heard. And so we've been working on that since the beginning of the fiscal year to improve that tool in both PeopleSoft and in Power, with the guiding principle of listening to the voice of the customer to help streamline and simplify the tool, but still maintain it to be an effective feedback source. Another initiative that we're working on as a follow-up to the last UCount employee engagement survey, we'll be rolling out a new survey later this spring that we hope will be rich in feedback, and we'll be working with leaders across the campus to work through that feedback and respond to it. And wouldn't it be great if we got a 70% participation rate on that? So looking forward to that. And while both of those will help us improve our processes, what I'm most excited about that we'll roll out later this fall is a new HR service delivery model that will begin to shift how we work with our business operations in a more consultative HR business partner. We are still tweaking that. We're formalizing the plans and the structures and then looking at our talent. And so more to come on that later this fall.
thank you. So we thought we would have folks come up and just talk a little bit. They say it much better than I do about what we're doing in business and finance. I'm going to ask them to stay here. We'll do one quick recap slide, and then we need to open this up. I know we're about 2 minutes before the hour, so we're happy to stay here. So just to recap, this is what we talked about. We did look a little bit deeper into our financial situation. Hopefully we didn't put anybody to sleep. We tried to look ahead at what was going to happen for the next year and what's happening out there for other academic medical centers. And we looked, obviously, a little bit at business and finance. I'm happy to open it up for questions at this point. If we have anybody that would like to ask a question that they didn't get answered in the presentation, or just any question.
Hi, my name is Leslie Blacketer. I work with the Employee Advisory Council representing institutional support. And we had a question, actually a two-part question. Why do we continue to build and lease expensive buildings? And would telecommuting for all admin staff cut costs?
I can take it or you can take it.
Well, let me start.
Okay.
So we are building new buildings. Part of the strategic growth plan, of course, is to move our services out to the population centers that we need to serve. And in some cases, those are going to be lease properties. If our lifespan is a 10 or 15-year lifespan of a particular community or population, then those typically are going to be leases that we negotiate and put clinics in place. Other cases, we may have a longer term life, like a 50-year or more life for an expectancy of a facility, like our hospital there in the League City campus. So we tend to build and own those facilities. It's common to think of those as expensive facilities, but we do benchmark. We keep track of that, and we can tell you that our expenses in building these out fall at the midpoint or less of the similar facilities that are being built around the state.
Thank you.
I can take the telecommuting, I think.
Okay.
We currently do have a telecommuting policy that allows us to assess the work relationship, but on a case-by-case basis, because not all situations or employees really are appropriate for telecommuting. The manager is responsible for assessing, the impact on the employee's productivity, the service to our customers, as well as the effectiveness for the work unit. And so the best way to do that is on a case-by-case basis, looking at the employee's experience, the employee's performance, as well as the work home arrangement. And so those are best done on a case-by-case basis while the manager is actually assessing the appropriateness of that arrangement.
Well, thank you very much for spending time with us today, and thank you for everything you do for UTMB. Have a good day.
UTMB Health, working together to work wonders.